Diversity is key to progress, yet it remains underrepresented in clinical trials. This disparity affects the validity of our medical advancements as we fail to fully consider women and minority groups. Get ready to unpack this crucial subject with our upcoming panel. Please welcome our moderator, Dr. Pranali Hoyle, professor and consultant at Neurodiversity of Northeast LLC, and panelists Parmjit Kaur, speaker at Parmjit Kaur LLC, Dr. Joseph Rosado, MD, MBA, physician, speaker, author, and educator at International Medical Consultants, Inc., Yasmin Samatar, co-owner of Mawadda, and Firaoli Adam, co-founder of Mawadda, as they share their thoughts on the topic, Diversity Matters, Why More Women and Minority Groups Must Be Included in Clinical Trials. We're excited to hear all of your insight. Thank you.
Tell me if you can hear me. Okay. Sorry. Hi, welcome everybody. We're very excited to discuss this topic, and I'm excited to introduce my esteemed colleagues here, Dr. Joseph Rosado, Parmjit Kaur, Firaoli, and I apologize if I'm saying your name incorrectly, but I would like all of them to introduce themselves. My name is Dr. Pranali Hoyle. I'm coming from a very behavioral analytic background within research. So I have 20 years of experience within applied behavior analysis. I work with children and adults on the autism spectrum, as well as conduct a lot of parent trainings and school consultation for children and adults on the autism spectrum. I'd like to introduce Dr. Joseph Rosado.
Good morning, I'm Dr. Joseph Rosado. Hello? Can you guys hear me okay? Can I get a thumbs up in the back? Okay, thank you. I'm a primary care physician by trade. My history in medicine is quite varied. I started out as a certified nurse aide at age 16, became an EMT, then an EMT paramedic, then a cath lab technician. Then I went to chiropractic school, then a medical doctor. Then I got an MBA in healthcare management, and within that, yes, what do you tell me to do?
Grab the other mic.
Does that work better? Oh, yes, much better. I said hip, hop, the hip. I'm sorry. I relapsed. So, went to medical school. After medical school, I got an MBA in healthcare management, and within medicine, I've done a lot of things, including medical director for a clinical trials, clinical research company. So I have quite a bit of experience doing clinical trials and research with specifically minorities. So that's one of the points that we'll be addressing today.
Okay, how do I follow that up? Okay, hi everyone. My name is Parmjit Kaur. A little bit about my background and how I fit in. So I am actually a project manager. I also serve as the executive vice president of PMI Southern Nevada chapter right here in beautiful Las Vegas. I also have worked in healthcare for almost 20 years. Don't be fooled by my young face, but I've been in healthcare for quite some time. But the reason I'm really here today is I am also a patient, like many of us actually sitting in this room. Whether you, if you go to the doctor to go visit your PCP, whether you go to your podiatrist, all of us are patients, right? So that I'm here to represent the patient perspective. So I'm a patient who was diagnosed with multiple sclerosis in 2008, and I'm going to talk a little bit later on about how I was not able to participate in a clinical trial because I was not made aware of it, but I'll talk a little bit more about that later. But being a patient is why I'm here today, and I'm also a patient advocate. So that's a long way of saying that is why I'm here. So, is it on? Hello?
Yes.
Yes, my name is Yasmin Samatar. I am a respiratory therapist for about 6 years and also the co-owner of Mawadda, which is a PPE company. And we launched our first patented disposable hijabs in November of 2022. And I'm very excited to speak today.
Hi everyone, my name is Firaoli Adam, and I'm also a respiratory therapist. I met Yasmin at school in a respiratory school and been working as RT for the past 6 years. And we also co-founded Mawadda, which is, like Yasmin explained, we are first pilot project being disposable isolation hijab. And we will kind of go over it later, the reason why, how we got into this business field. Definitely, it was not something that we planned, but you know, the best thing is when you're the one that actually facing the problem, looking for a solution, you kind of come across something that hopefully can make a difference in the future.
Amazing. Thank you so much, everybody. And I'm so excited to welcome all of you to this panel. I'm excited to talk about this topic. It's a very important topic, near and dear to my heart, especially because I do a lot of research within the autistic population, where minorities and people that live in specific rural areas who still don't know what behavior analysis is. They don't know that the treatment exists. They don't have access to it. So really including a lot of diverse populations is very important to research. So my first question, or the first question for the panel, and I'll talk briefly about this as well, why minorities may be resistant to participation in the clinical trials. So as we know, past research has indicated that there's definitely poor ethical standards that have existed. So one of the studies that, you know, I'll speak to is the Little Albert research, which was conducted in the 1930s. I'm sorry, I am not tall enough for this panel. It's just nuts. So bear with me, sorry guys. So the 1930 study that was conducted with Little Albert, where it was an operant conditioning study where he was exposed to various stimuli, and one of the stimuli he was exposed to condition fear was a white rat. So then every time he saw the white rat, he would, you know, engage in crying and screaming behavior, and this was done through that with John Watson in the 1930s, you know, a very famous behavioral scientist that we still admire. And, you know, a lot of his studies do have valid and merit, but that particular study did condition some fear into a 9-month-old child. So it's that aspect of consent and assent that we really want to talk about, and why people might be resistant to participation in certain research when information is not given to them of what's really happening within that research. So I'll pass the question over to the panel and let Dr. Rosado and the rest of the panel add to that.
Who here is not, I repeat, who here is not familiar with the Tuskegee syphilis study? Hands up. Okay, so for those of you that are not familiar with that, I will do a brief recap of that. That study was conducted in Tuskegee, Alabama in the early 30s, where it was an observational study of African American men with syphilis. However, they did not receive treatment for their syphilis. They were being observed, because a little background on syphilis, you have 3 stages: primary, secondary, tertiary. Primary syphilis, you notice a chancre, a painless chancre or a sore in the genitalia. It's pretty asymptomatic. Secondary syphilis has that chancre in conjunction with pain, general malaise, loss of hair. Sometimes they get a rash on the soles of their feet and the palms of their hands. And then it progresses, if not treated, for 20 to 30 years, and they develop what's called neurosyphilis, where the virus, or the bacteria rather, makes its way into the nervous system, goes into the spinal cord, and now they develop neurological changes, i.e. behavioral changes, because it affects their brain, which is one of the causes of death that's been attributed to Sigmund Freud. He had tertiary or neurosyphilis. They also may develop what's called tabes dorsalis, where it affects the back or the posterior column of the spinal cord. And when they're walking, they walk like if they have flippers on their feet. And so they're slapping their feet on the ground. So because of the progression of this disease and the marked symptomatology that's evidenced with this disease, they opted to evaluate and monitor these individuals from the 30s on. Now, fast forward to the mid-40s, that's where they developed and discussed and discovered that penicillin was the conclusive and definitive treatment for syphilis. However, treatment continued to be withheld. Fast forward until the 70s, that's when they realized what they were doing to these men, that they were infected, they were all sick, and none of them had received any treatment. And it wasn't until the mid to late 90s that former President Bill Clinton decided to openly apologize for that situation. Now, as a result of that, that is very prevalent and predominant in the African American community. So, as a result of that, many African Americans are reluctant to receive any medical care, any medical attention, because of fear that they may be sick and will not receive the treatment or the care. Imagine that you're proposing investigating a medication that's geared specifically for an African American population. You're not going to be able to get any subjects because of the past history and lack of trust that exists in the research facilities, research studies, and the medical profession as a whole.
Okay. All right. So before I continue, I just want to let everyone know I am extremely nervous, and that is why my voice is shaking a little bit. Would you believe it? I'm an inspirational speaker, and would you believe speakers get nervous too? So I'm nervous. So bear with me. So I think there's a lack of trust with a lot of healthcare providers and with doctors specifically. I feel that a lot of folks don't feel that they can freely speak with their providers. I'm one such individual. When I was diagnosed with MS, I remember I would have conversations with my doctor about certain symptoms I was feeling, certain things that I was going through, but he did not listen to me, and so I did not feel that I could openly have a conversation with my doctor. And then so in my family, a lot of my family does not speak English, so my family comes from India, so a lot of my family does not speak English, and so I think because there's that language barrier, a lot of folks don't know. Number one, they don't know that there are clinical trials available, and number two, they don't know the questions to ask. And then once they do discover that there is a clinical trial, I think that they don't know, again, what does it mean? What does a clinical trial mean? I know, again, my family does not speak English, and so I think that there's that lack of understanding. And so I think that is one of the reasons. And again, also, guys, I apologize. I keep looking down on my phone, and I promise you, I'm not looking at Instagram. Okay, I have my notes on my phone because I want to make sure that I don't overlook something that I want to mention today. So,
kind of referring back to the topic before I dive into it, to give you a little bit of a background on what we do. As a respiratory therapist, can you guys hear me? Oh, that's a lot better. So as a respiratory therapist, graduating from our bachelor's degree and going into the field, no one really prepared us on how it is being a Black Muslim woman in the healthcare field. So we're just going in as newbies, trying to kind of like assimilate and not stand out, right? So going into our first OR surgery as respiratory therapists, remember my preceptor being precepted going in, you have to go in having sterile gowns on. So I had my hijab on going in, and my preceptor said, oh, make sure you tuck your hijab in. And I never thought like, oh, my hijab is going to be an issue going in, right? So I was like, oh, okay. And then I start tucking it in. He's like, oh, get the back. And I'm like getting the back. And now I'm like extra nervous. I'm like, am I bringing infection into my patient's room? So as we go in, another nurse says, "Oh, make sure you tuck the back of your hijab in." And I'm like super nervous. You can't touch any of the sterile items around you. So I'm going in, and during the whole procedure, I'm hyper focused on my hijab, and I just have so much anxiety to the point where by the time I left the room, I had no idea what were the skill sets that I learned. And I just felt like a sense of relief, like, oh, I'm not impeding anyone's care in the room. So going back into the department and speaking to fellow Muslim women, and they had the same issues too. And I was like, oh, but you're not thinking as newbies, like, oh, let me create something in the system. So we're just going in and putting a temporary bandage, per se, on everything. And going into COVID later on is when we later discovered a lot of the issues that we're dealing with kind of brought to light, especially going into COVID patients' rooms. And now you have to fully gown in and gown out, and you're still wearing your hijab for 12 hours, and you're going from one room to another, and you're going to cancer patients' rooms, neonatals. So, and you're going home with the same hijab. And that's when we discovered like the word PPE was so prevalent, but we were kind of left out with our hijabs. And so that's when we later traveled and saw other hospitals and the type of care they provide. And soon enough, saw that they had, what was it called, a beard cover? And we're like, if they have beard covers, why isn't there hijab covers? We're like, okay, we're just kind of like researching to buy something. And that's when we saw that there was articles out there, but nothing to buy or in the system. So that's when we went on our journey, and Firaoli can go a little bit into it, on our journey about how we developed our PPE hijabs.
Yeah, so definitely everything everybody's talking about is an issue that we all faced. Being a woman and especially minority, nobody caters to you is something that we discovered. And mainly it's because nobody talks about it. Nobody say this is an issue. And we understand that. But now we're just like, okay, we are telling you guys this is what we're facing, right? Like Yasmin explained earlier, going from room to room, we're trying to put temporary bandage on, talking to the manager, how we can stay in one unit and not go all over the place. And it was just hard trying to survive the COVID period. On top of that, worrying about family and different patients, it's just like, okay, why didn't anybody, develop something for us? And it's not only like, making sure there is diversity and inclusion, but also at the same time is patient safety. Is we want to come up with this so we can prevent, spreading infection. That's really important to us. We're just like, we had family members that were going to different fields in healthcare, and we just don't want anybody else to face the same issue that we are. So once we said that, we make sure we took, I think 6 months off from work, just focusing on research and how, PPEs are made. So looking for manufacturer that is in USA, and also, going through the FDA, since this is something that's going to be in a hospital setting. It was definitely a process, but once we brought this issue to light, we had a lot of Muslim women that wear hijab, actually different minority group reaching out to us and telling us how much, they needed this. Some of them had to leave the country where they're in medical school and trying to practice to a different country or state as well, to see who's gonna let them just practice with their regular hijabs. And some people do know this is an issue that is out there, but there is no solution. We are pretty new at this, but at the same time, having the community behind us and everybody support us, knowing that how this is important, is something that gives us a push. And definitely, I agree what you were saying. It's kind of hard having that trust when you feel like you're not included. You don't feel like you're included, because it's like, okay, everybody was so, taking COVID very serious, and obviously everybody got used to the word PPE, but we were left out, and we didn't want anybody else to feel that way. So we focused on it, and we launched in November, and hopefully soon enough you guys can see it at other hospitals where you guys participate as well.
Amazing. Thank you so much. It was such various perspectives. So obviously, due to the fact that we're shorter on time, I want to make sure that we address how we can address the issue of including more diversity in clinical trials, making sure that the information is available to various demographics. I'll speak to a little bit from my own perspective. When I was conducting research for my dissertation, for my thesis, I ensured that when my IRB application was being processed, that some of those inclusion and exclusion criteria were coming from a very culturally informed perspective. So making sure specific wording was included, and making sure when I created the flyer that it was being shared on various social media sites and community platforms, and making sure that when the IRB passed my dissertation to be approved, that all of those informed consent criteria were included on being, when they were participating in the research, they knew exactly what to expect. There were no hidden agendas. It was clearly identified what specific treatment and baseline conditions they were going to experience. So I think that's also really, really valid, is to make sure that you're being very transparent about what you're conducting research on and how is this going to benefit the society in general, that social significance aspect of it. So I want to pass that on to the rest of the panel, Dr. Rosado, Parmjit.
Yes. So are there any Spanish-speaking members in the audience? Anyone speak Spanish? One? Two? Okay, cool. So this story will sound really interesting. So there was a clinical trial that was being done in the Bronx, where I'm originally from, and it was a sleep study, and they asked a woman about how she was able to sleep, or was she able to sleep the night before, because they had started her on this medication. And it was being conducted in Spanish, and her response in Spanish was, no pude dormir porque había unos tigres haciendo una bulla. Translated, no, I could not sleep because some tigers were making noise downstairs. They transferred her to psych. Why? Because she's hearing tigers. She's Dominican. In Dominican Republic, the phrase tiger or tigres is designated to individuals, young guys that are hanging out, just causing trouble. So she said, había unos tigres haciendo ruido. There were some tigers making noise. Oh, she's got a psychiatric problem. She's hallucinating hearing tigers. In an emergency room in Arizona, an individual came into the emergency department with seeing orange and hallucinating and completely disoriented. And when they evaluated why he was experiencing these symptoms, he said, well, the only thing I've done is take this medication. This medication was started last week by my cardiologist. The medication is Digitalis. It's used for an irregular abnormal heart rate or heartbeat. On the prescription, on the label, it read in English, take once per day, ONCE. He did not know how to read English. He read once, ONCE, which in Spanish means what? 11. So instead of taking once per day, he took 11 pills and almost killed him. Okay, so these are challenges that exist not only in medicine, but also in clinical trials. And if you don't have an individual that can speak to your language, whether it's Indian, Spanish, whatever languages that you're addressing, and so as a result of that, the solution, because we don't want to be all about gloom and doom up here, there is a solution, and that is the Diverse Trial Act, DIVERSE, Diverse Trial Act. It is a bipartisan, believe it or not, a Republican from Indiana and a Democrat from California, and they are bolstering finances. I see someone nodding, so you are familiar with the trial, yes? And so the advantage of that is that it's going to bolster bringing in underrepresented populations into clinical trials as well as providing the proper funding for these clinical trials.
Wonderful. So I'm going to touch a little bit on my personal story. I'm just going to touch on this. I'm going to share my full personal story later on. But so my story. So again, I mentioned to you all that I was diagnosed with multiple sclerosis in 2008, and when I was diagnosed, I was put on a medication called Rebif, and it is to suppress my immune system because, as many of us know, multiple sclerosis is an autoimmune disease. When I went on Rebif, I had a lot of side effects from the medication. And so after 2 years, I made the decision after speaking with my doctor that I would no longer be on Rebif. And so we switched me to something called Copaxone. Once I got a Copaxone, tried Copaxone for a year, and Copaxone was not working. My MS was still progressing. And so my doctor and I, again, went back to the drawing board to see what else is an option. What he did not tell me is, at the time, so let me backtrack. So at the time, he recommended to me that I should be on something called Tisabri. And so Tisabri is an infusion. It's a once a month infusion. With Tisabri, it carries a risk of PML. And PML, I'm not going to give you the medical term because I'm going to jumble it. PML is a brain infection. Now, one of two things happens if a patient gets PML. Either that patient essentially becomes a vegetable, or that patient dies. And so clearly, I did not want to go on Tisabri. If you test positive for the JC virus, how many of you have heard of the JC virus? Okay, so over 80% of Americans actually test positive for the JC virus. If you test positive for the JC virus, you are more at risk of getting PML. I tested positive for the JC virus. Still, my neurologist wanted me to go on Tisabri. And anyone who knows me knows I'm an anomaly. So if something is going to happen, it will probably happen to me. And so clearly I did not want to take the risk of going on Tisabri. So at the time I said to my doctor, let's explore other options. What he did not tell me at that time was there was a clinical trial for something called HSCT. And I'm not going to, again, I don't want to jumble the words, so I'm not, basically is a chemotherapy-based stem cell transplant. And the thought is that this stem cell transplant can stop the progression of MS, and it's over 85% effective in stopping the progression of MS. At the time, there was a clinical trial taking place at Northwestern University Hospital in Chicago, but I was not made aware of this. So, and I'll touch on, again, on my story a little bit later on how I found out about this clinical trial. So I'm mentioning this to say, providers need, in my humble opinion, I think that communication is going to be important. I think it's important for providers to communicate with their patients which clinical trials are coming up, possibly run a query on which patients they have with certain conditions and which clinical trials are coming up. Run a query on what is the exclusion and inclusion criteria. Run a query on which patients, because we need to factor in patient consent, which patients consent to their information being shared and being contacted about these clinical trials. And so I think communication really is the root of it. I think it's important for providers to communicate this and then also take into account that not all of their patients are probably English speaking, you know, like folks in my family who speak Hindi or speak Punjabi, or you have other folks who maybe speak Spanish or another language. Take that into account and then communicate the clinical trials and what that means. What does that mean to the patient? And then explain it in a way a patient can understand in simple terminology.
Thank you. So that, unfortunately, that's all the time we have. We do want to make sure if there's any questions, you please come and find us during the lunchtime. Unfortunately, that is all the time we have. And I'll hand the mic back.
Okay, thank you. Thank you today, everyone.